You're about to hear a conversation about doing less, but it isn't really about doing less. It's about time, about recognizing the patient you can't fix on the pavement or in their house and having the discipline to move. This podcast was recorded at Trauma 2030 at the Royal College of Surgeons in December 2025. Trauma 2030 united experts and innovators to shape the future of trauma care, and over the 2 days it explored breakthroughs in science, systems and frontline practice, fostering collaboration across disciplines. The symposium aimed to inspire research, inform policy and build a bold roadmap for trauma care worldwide. That was the intention of the organisers, and it did feel like a meeting trying to take trauma seriously as a system and not just a set of procedures. We were lucky enough to record a number of conversations at Trauma 2030, so you're going to hear more in upcoming episodes. And this one, I'm talking to Harriet Tucker, London's Air Ambulance HEMS Governance Lead and Trauma Team Leader, about damage control pre-hospital care. It's about recognising non-compressible haemorrhage, about restraint, and about accepting that sometimes the intervention that matters the most is speed to a surgeon. Harriet will also be speaking at Tactical Trauma, which runs from the 2nd to the 4th of November in Sundsvall, Sweden. A fabulous meeting. And if you're part of that world, you'll have heard of the meeting. I'm sure we'll be wanting to get there. Incrementum is only 8 weeks away, and if you've been meaning to book, now is probably the time where you need to stop meaning and have to have some action. There is only a few tickets left. And one final thing. If podcasts are part of how you learn, not just from St Emlyns, but all of them, that's why MedPod Learn exists. It's free to download. There's a month free if you want to explore the structured side. And after that small subscription, it lets you log your listening time across all the podcasts on the platform, not just ours, and then turn them into something you can reflect on properly. Alongside that, there's 5 MCQs for every episode to check that knowledge you learn is really going in. Pricing adjusts globally. We recently had a subscriber from Somalia pay 4 pence for an entire year. So if you're thinking about using it, please do. And if you already are, thank you. But now here's our conversation with Harriet Tucker. Welcome to the St Emlyns podcast. I'm Ian Beardsall, and I'm at the Royal College of Surgeons for Trauma 2030 and managed to grab one of the faculty to have a chat about a really interesting topic. We're going to be getting onto that in a second, but first, Harriet, would you mind just introducing yourself to the listeners?
My name's Harriet Tucker, and I'm a consultant at London's Air Ambulance and a HEMS Governance Lead at Air Ambulance Kent, Surrey, Sussex. And I also work at St George's as one of the trauma team leaders at one of the London major trauma centres.
So you've got lots of different roles, and we're going to talk about 2 of them, really. We're going to talk a bit about the pre-hospital work you do, and we might talk a bit about trauma team leadership as well. But there was a big topic yesterday, which I thought was fascinating, which was about damage control pre-hospital care. And Dan Nevin gave a talk, and we'll focus a little bit on what he said and your experience of doing it, about actually doing less in the pre-hospital environment. So as a pre-hospital practitioner, when I was doing HEMS, it was all about, we're going to do this, we're going to do this, we're going to stay on scene, we're going to make sure we've done everything we can before we go to the hospital. But what Dan was talking about, and I think what you've been working on, is this idea that sometimes you just need to get the patient to hospital. Can you just tell us a bit more about that damage control pre-hospital care and the SOP that you've been working on together?
I think it's a really interesting approach, which we've evolved over the past 5 years, testament to work of a lot of people, but based on 2 key principles. One is using time as a treatment, and the second is doing interventions en route or minimising interventions and focusing all your interventions on essentially bleeding or exsanguination. And it's a bit of a strange turning the usually really high standard of care, everyone comes in with everything done perfectly, to minimising interventions to only those that save life and deprioritising ones that are not essential at that time in the patient's pathway. So it gives our teams permission, if you like, to focus on the things that will get that patient to hospital alive, and arguably put a bit more emphasis on the trauma team to do some of the interventions, such as a definitive airway, that might otherwise have been expected to do pre-hospital. And it's evolved because we're recognising there's a group of patients who are dying pre-hospital from bleeding, from non-compressible haemorrhage in the torso and the abdomen that we cannot fix. And ultimately, they need to be in a theatre with a surgeon to give them the best chance of survival.
So there's a few key things to that. And when Dan did the talk yesterday, he talked her through a case of a young chap who'd been really severely injured, that arrived on scene, and to all intents and purposes, for want of a better term, he scooped and ran with the patient. He did a couple of key interventions. He packed a wound, he put in a trauma line, and then they drove. And whilst driving, they did a few things. And that was very much against what I was certainly been practicing when I was doing HEMS, and I think we talk about a lot, which is the let's stabilise the patient, let's get a definitive airway, let's think about, and Dan was very open and said, normally what would have happened was we'd have done an airway, we'd have done thoracostomies, we might have done a thoracotomy, and then we'd have left the corpse in the patient's house. And this was a different type of approach. So the key interventions, it seemed to me, were about that non-compressible hemorrhage. We've heard that a lot over the last few days, stopping that bleeding, and then the other key bit, which we'll come on to a bit, is talking about the surgeon being ready to do stuff. So talk us through that pathway. If you're confronted by a patient who you believe has severe life-threatening bleeding, they're teetering on the edge of death, you arrive on scene. According to this pathway, what are you going to do on scene? What are you going to do in the back of the ambulance? And we'll talk a bit later about how you're going to pre-alert the hospital that's expecting you.
So it's very much a focus on aggressive volume resuscitation, which you need vascular access for, and immediate hemorrhage control. And this comes out of the work that Zane has done, focusing on exsanguination. We know that once you've had an arrest, you've got about 5 minutes before we have no survivors. We know that exsanguination happens rapidly, but we also know that our time to scene, and this is probably the same across the UK, is probably an average of about 20 minutes or just under. But we know that people are dying between 15 and 30 minutes. So the whole tenet is to get there and say, for example, you arrive on scene, there's someone who has a penetrating injury to their chest. They look awful. They're displaying all the signs of exsanguination that we all know. And actually our priority, therefore, is to recognise that we cannot treat that pathology. So it might be they are bleeding into their chest cavity. It might be they have non-compressible junctional hemorrhage. They need a surgeon. So our job is to recognise that, which is the first key. And then one big line. So you talk about maybe saying normally you'd have 2 lines well secured. We need 1 line to give volume through, 1 large line. Starting volume much earlier, which is blood, red cells, plasma. And then essentially ensuring there's no obstructive shock. So you might do a thoracostomy, but you might do less station than you might otherwise do, or analgesia. And instead of thinking, oh, let's possibly pressure ventilate, actually, if they need airway support, a bag valve mask, an eye gel, rather than spending time. And it is all about time and balancing the time taken to do an intervention as to where that patient needs to be. So essentially, vascular access, volume, hemorrhage control as you're able, and minimising everything else. And the things that get minimised are things like the definitive airway, immaculate spinal precautions, and packaging in the way we would traditionally do, because that focus is on resuscitate and moving rather than stay and play.
And it's important to say that a lot of the cases that Dan was talking about, and I think you refer to, are penetrating trauma, which I know you see a lot of in London, less so in Hampshire. We don't see as much penetrating trauma. But I think the key here was that non-compressible hemorrhage, usually from penetrating trauma rather than blunt trauma. And the patient identification seems to be the key bit. How do you think people can work out whether they're going to do this damage control pre-hospital care or the bit where they try and do interventions? Because that decision there is the absolute crux of the whole thing.
Yeah, we spent a lot of time talking about this both yesterday but also over the past few years. And it comes back to that immaculate clinical assessment on scene, reading the history, hearing the history, and putting that in your assessment. So the reason we've got more penetrating injuries in our guideline predominantly tries to focus on penetrating injuries in impending or actual cardiac arrest or rapidly exsanguinating, because they're the patient group is arguably easier to focus on. Big blunt mechanisms, falls from height, big deceleration injuries, we know have polysystem injury, including head injuries. And one of the things we've done with every single patient is go through to ensure there's no harm. So again, much easier to draw out a penetrating injury to the chest, abdomen, likelihood of a vascular injury, solid organ injury, because you've got one injury pathology or one injury pattern, rather than the blunt injuries, which we all know are much harder and more challenging to identify. So clinical assessment, mechanism, ultrasound we tend to do en route for these patients. We wouldn't necessarily spend a lot of time on scene, and using your clinical acumen to decide that. But again, we know that diagnosis is hard, and that's one of the reasons we review every single case immaculately to make sure we've done no harm by undertaking the strategy, as well as benefiting the patient.
I'm fascinated by the human factors idea that you turn up on scene and actually you've got to change your mindset from, I'm going to do everything, we're going to set up a kit dump, we're going to start preparing for an airway, to, we're just going to do these few things and get in the ambulance. And there's certain things that really struck me. The first was, as a pre-hospital practitioner, I wanted to do things. I wanted the experience that I trained for. We didn't get a huge amount of opportunity to do thoracostomies or thoracotomies pre-hospital. And so if I saw the opportunity, my first thought was, wow, I'm going to get to do what I've trained for. So that was one thing that I found really interesting, was this idea we're telling people or asking people to actively recognise that they're not going to do the things that they actually really want to do.
Yeah. And I think it's using our patient data, for want of a better word, so reviewing every single patient case, looking at the big data sets and realising what we can treat pre-hospital and what actually our skill set at that point is that recognition, and it is not the technical skills. We know that when we look at our thoracotomy cases, if they have anything other than tamponade, we are usually less likely to be able to resuscitate them and get them to hospital. So it's acknowledging the limitations of a skill set that we have pre-hospital and recognising that, yes, you've been drilled, that if you've got someone who's arrested in front of you with a penetrating injury, say to the groin, maybe you do a thoracotomy. But actually we know from the data sets that their outcomes are not good. So actually it's far better to recognise within yourself, I could do this, but I won't do this as a mature clinical team and rapidly transfer onwards, rather than trying to undertake something that ultimately will not benefit the patient in that context. But again, that's a huge strategic shift. It's a huge mindset shift, as you say, for the teams. And that's one of the things we try and teach when we're implementing our training, our workshops, our skill sessions, of that deprioritization of skills that you would otherwise normally want to do. And everyone comes in, as you say, saying, I want to place trauma lines, I want to do thoracotomies, but actually saying, we've got 2 14 gauges. That's enough. What are we going to do on scene that will benefit the patient, and how are we using our time efficiently, rather than it's about you and wanting to do those interventions. But that requires a cultural piece that we all know comes alongside an SOP implementation. It's the training, education, culture and governance. And that's the bit that we're trying to focus on now within our teams.
I'm guessing you're the same in London as we were in Hampshire, which is spent a lot of time getting our paramedic colleagues from the local ambulance service on board with what it was we were going to do and helping them understand the different interventions we wanted to do on scene and what we might be getting up to. So they got to the stage where if a pre-hospital team arrived, the ambulance service crew would say, okay, you're going to set up for an RSI now. How can we help? One of the challenges is now you're saying to a team that you've prepared, we're going to do a bunch of stuff. You've now got to communicate to an ambulance crew who've been first on scene with a patient. They've been managing difficult environment, relatives, emotions. And now you just go in, scoop them up, go out, very little time to explain what you're doing. How have you managed to get the other crews on board that this is a special case and that's why you're doing something different to the thing you've been telling them for years that you really want them to help with?
Communication, as you say, with our partner teams, so London Ambulance Service, whichever ambulance service you're working with, absolutely key. And I guess 2 instances of that recently. We have recently done joint training with our APP, or Advanced Paramedic Practitioner colleagues, at one of our training days to explain the shift in strategy. And we've talked through those principles of time, of non-compressible haemorrhage, of rapid onward transfer, but putting it into the context of how we arrive on scene, how we move the patient. Because as you say, nothing works. No pre-hospital critical care service works in isolation. So bringing them along with us, explaining the whys, putting it into context of time as a treatment and an intervention. And then using our governance days to explain to the wider London community about the importance of this particular group of patients. And they're small numbers. It's probably about 20 patients a year. So again, speaking to how you train to that, how you explain to a large number of ambulance service colleagues, you might never see this patient. But actually, this is the patient group that we're trying to target, and explain the whys and wherefores, and almost asking for forgiveness before you've done it, to explain why you're going to be rapid, to explain why you're going to minimise other interventions, to explain why you're going to be less neat and thorough than you might otherwise have been, is absolutely key. And sharing the learning from our governance, sharing the learning from our case review process, both with our major trauma centre colleagues, but also with our ambulance service colleagues, to bring them on that journey with us. Because it is an iterative journey. We designed the SOP that was based on data from our own patient cohort, that was based on expert opinion from our clinicians. But every case we review, do we need a change to that SOP? Is the SOP fit for purpose? Because it's part of that ongoing iterative process to make sure we are targeting the right group of patients with the right interventions and arguably with the right omissions of care, and giving permission to those omissions to facilitate onward patient transfer to the place they need to be.
So you've got the patient from the scene, you've scooped them up, you've done the few things we talked about. So stopping compressible hemorrhage, trying to think about how you're going to start active, aggressive volume resuscitation with blood, thinking about obstructive shock and making sure that's not the problem. And you're starting en route to the major trauma centre in the back of an ambulance, maybe half an hour away. Dan yesterday described trying to do some interventions in the back of the ambulance. There was a question from the audience about safety in the back of the ambulance. We're not saying that people are riding around without belts on in the back of ambulances, trying to put arterial lines in and doing other interventions. I don't think that's the message we're giving here. It's At times, you might need to pull the ambulance over for a few minutes to do an intervention and move on. Have I read that right?
Yeah, you're absolutely spot on. It is all about being safe in the back. And that is a key message we need to get across. Just because we are rapidly moving and attempting to do interventions in the back of an ambulance does not mean we're unsafe. And it doesn't mean our colleagues in the ambulance service and ultimately the patient is unsafe. So it's focusing again on what you need to do before you move into the back of the ambulance. And to your point, again, it's generally vascular access, volume, wound packing. Then we load into the ambulance, make sure the patient is safe. And we will strap ourselves in and we will say to the ambulance team at the front or our paramedic colleagues, we may need to deliver an intervention en route. And that may well be a thoracostomy and or the placement of an arterial line, the Seldinger wire to start with. And at that point, we will say, in a minute, we need you to pull over safely. So we give them time to pull over safely, deliver the intervention, and then restrap ourselves back in, restrap the patient back in, and keep moving forwards. But the key distinction is whereas with a traditional major hemorrhage patient, we will be doing all of this on the pavement in the field, as in a literal field, before we start moving to hospital. But we know that the time element is key. So the more we can optimally and efficiently use the time we have with the patient, so from arriving from patient side to getting to hospital and ultimately to a surgeon, we need to use that time well. So that is doing things safely in the back of the ambulance, but continuing to move forwards. Even if that means pausing for 30 seconds, we're still making progress towards hospital rather than still being at scene and still a fixed period of time away from the hospital we need to be at.
So you've got the patient in the back of the ambulance, you're moving at speed towards a major trauma centre, and you now have to communicate somehow. And somebody like me or you, in our other role as a trauma team leader or one of the people working with us, is going to take a phone call. It strikes me that this is going to be a difficult environment to give a full at-mist handover as part of that pre-alert that you want to give to the receiving service. From the pre-hospital sense, what do you try and communicate at that point?
Yeah, I think there are two things to bring out of this that have come out of reviewing the cases and learning with our major trauma centre colleagues is that actually the pre-alert time is less. If you're thinking we are trying to minimise time on scene and we're trying to move towards hospital, the time you have that you would traditionally have to place that pre-alert is truncated. So we use our paramedic colleagues in our emergency operations centre to place that pre-alert to give the most time to the trauma team to prepare for arguably one of the sickest patients they will receive in that shift. So first thing is it's an early, slightly different place of a pre-alert by the paramedic in the EOC or whoever our dispatchers are. And the second, as you say, it is truncated. So instead of saying this is so-and-so, they're 35 minutes ago, they fell out of a fifth story window, it's damage control, penetrating injury, thorax. And giving that information to the hospital team means they can start to prepare an appropriate theatre. By default, these patients will be code red, and we should say that in our pre-alert. We will say whether adult or paediatric rather than an age, because that will affect the system response and a team that comes down. But essentially, it's limited to the information they need to have. So code red, damage control, anatomical location of injury, and then adult or paediatric. And that's the information we pass. And that's part of the work with our major trauma centre colleagues, is to develop that understanding that we probably won't have time to give a set of obs. We probably won't have time to deliver meticulous details of interventions. But part of the damage control approach is that understanding that they might not have a definitive airway. They might need a further pit stop in ED to perform one or another intervention. So it's shifting that mindset of the hospital team to have more things ready than they arguably would do for a normal standard major hemorrhage patient or an anaesthetised traumatic brain injury patient.
So we've got the patient and you're about to pull up at hospital. And let's imagine now with the trauma team leaders, the thing that really struck me is that this is changing entirely how you're going to function in the resus room and what your thoughts as a trauma team leader are, and also what you need to have available, because it's clear to me that not all surgical services in the UK are going to be able to respond in the way that perhaps you can in London. I certainly know that there'd be a challenge for us where I work for a patient who had those sorts of injuries to go straight to theatre and to find a surgeon who feels comfortable with doing that sort of operation. But let's put that to one side and imagine for now that we've got a surgical team who are happy to go into a body cavity to try and stop bleeding. You're a trauma team leader. What do you say to prepare the team who usually have been used to, okay, let's do A, B, C, and go for CT. How do you prepare them both before in training and on that day when you've got to form a key team in that very brief moment you have?
One of the key parts of working within the system is working with the major trauma centres to understand what damage control is. or damage control pre-hospital care is. So the pre-piece or the pre-prep is that training education, explaining in the interest of time that these patients have come to hospital with deliberate omissions of standard of care, as we've talked about. So one of that is preparing the anaesthetic team that they might need an endotracheal tube and or drug-assisted intubation and or ventilation as appropriate. The other is thinking about those other bits of care that might not need to be done in resus. So it's all about that rapid moving forward. So as a TTL, you brief your team that we've got a damage control patient. Explain what that is, because again, to your point, not everyone might be familiar. But essentially, it's a pit stop in ED. These patients need to be in theatre, and that is probably the key cultural bit to explain to teams, is that they'll come in, they'll be super unwell. We know from the PPRO data and from Malta, they are shocked. They're physiologically unstable, they're metabolically unstable, and they will have, arguably at the end, a high injury severity score. But pit stop in ED, a wristband, 2 wristbands, you're probably not going to do any immediate imaging unless it's to determine which theatre they need to go to. So chest x-ray, fast, pelvic x-ray, potentially. And then doing everything you need to do, arguably, in the anaesthetic room or in theatre with that concurrent activity. And we know this happens pre-hospital. The more you put on a pavement, the harder it is to leave. It's the same in resus, isn't it? The more you put into a resus bay, the harder it is to extricate yourself. So really clearly signposting to the team that we are doing the minimal interventions. They don't need a catheter here. They don't need an extra line here. They don't need the arterial line here. That can all be done in the anaesthetic room or in theatre. And then that speaks to your other point about the surgical capability, capacity, because a lot of this is about bringing the surgical team along with you, bringing the anaesthetic team along with you, and reminding them that these patients may have been resuscitated, but they're still actively bleeding. And actually, they may look a bit better, but without that hemorrhage control, which needs to be delivered by a surgeon, they are not going to survive. So it is a big strategic piece. It's a big cultural mindset shift. But part of our jobs as TTLs is to signpost the team to that. So pit stop ED, keep moving towards theatre. These patients are likely not going to CT because it won't give any information that will benefit the team at that point in time. And they will likely rapidly transfer onward to a theatre that is appropriate within your trauma system.
The patient's arrived, you've briefed the team, everyone's on board, they've made it for pit stop into ED. Just talk me through what happens next. So do the pre-hospital team take the patient to theatre, or is that down to the TTL or the in-hospital team? How do you get that next step, which is we're going to leave the resus room now and we're going to get to theatre? Who's going with them, and how do you get them into the anaesthetic room and then beyond for what they actually need?
This is very much a work in progress. I think we've got our REBOA standard operating procedure whereby the pre-hospital team will stay with the patient and go with them to theatre. This isn't so set in stone for the damage control SOP. But if we're thinking, as you've said, about minimising time, maximising efficiency of time, there is potential for the team to move on with the patient up to the operating theatre if they're so unstable that a handover will delay onward care. Because it's all about physiology. It's all about understanding response, interventions, and how that patient has been. And if the best person to stay with the patient is the pre-hospital team, then that ultimately is what the patient needs. If there is the opportunity to do a rapid handover to the ED TTL or to the surgical TTL, so be it. But the vast majority of these patients, it's likely that the team will move as one up to theatre, and then you will do your damage control handover as you would in theatre to the assembled surgical and anaesthetic team. But that's up to each individual major trauma centre to work out their own processes, because we can't mandate one approach. But if the team is needed to stay, then that will happen, because ultimately that benefits the patient.
You've got the patient's in theatre, they're having some surgical stuff done and hoping for a good outcome. And from Dan's case yesterday, I think these often are young people who can tolerate awful insults to their physiology. And if you can stop the bleeding and you can get the blood flowing again, you do have a chance to save lives. What's the last step of this? The case review, the follow-up, the support for the pre-hospital team. What do you do next, both in the moment and then maybe a week or two down the line? Because these cases won't happen often. I'm sure these are high-intensity brain events for the clinicians doing them. How do you make sure you look after the teams who are doing it?
A really important question. And I know we all are aware of the importance of both hot debriefs, cold debriefs, but also how they fit into both emotional and psychological well-being, but also learning, education, training. We've already spoken that these are really rare cases. So probably we've cared for 22 patients over just over a year. So again, very small numbers. So using that time, going away, checking everyone's all right, explaining why we didn't do. And to your point about explaining to our paramedic colleagues, omissions of care, this is the ideal time. While you're gathered in an ambulance bay, you've cleared your kit away, you've had a glass of water, you're having your hot debrief as to why you didn't do stuff. Because we don't want ambulance teams to go away thinking we didn't do things that we should have done, because that will sit with people. So using that opportunity to explain why we didn't place an ET tube, why we didn't pull that leg perfectly, why we didn't warm them as well as we might otherwise have done, because it's all in the interest of time and getting to the place they need to be. So that's the first bit, that immediate hot debrief, and using that as an educational teaching moment for our teams and also for our major trauma system colleagues. And then the next piece of that is the cold debrief, or the case review, if you like. So every single one of these cases, a group of us, both paramedics and doctors, will look through. And we look through and we say, did the patient meet our SOP criteria? Penetrating injury, impending or actual arrest, rapidly exsanguinating. Was there any harm to the patient by adopting this approach? Were there any potential unintended benefits from adopting this approach? Are any changes to our operating procedures needed? And how do we share this learning with the wider team? And so every patient we go through with that, and then quarterly we review all our cases and put an updated sort of memorandum together to share with the teams. These cases do go through our normal governance processes, so D&D, rapid review on a daily basis as is appropriate, but with particular attention as to whether this process is having unintended benefits or unintended harm on our patient group. We meet 6 monthly to review the cases and take that to our governance board meetings just to see if there's any changes needed. So yeah, a really parallel process of training, education, governance, support for the teams. And then all that is implemented into things like our skills sessions, going out to an ambulance station where we can actually get in the back of an ambulance, drive around and do this safely. So how do we need to implement that into training and education, which we all know is the parallel work to any SOP or change in practice to ensure that it's done safely and effectively.
So I'm just going to double check I've got everything clear in my head. So this is a small group of patients, usually penetrating injury, who are bleeding to death from bleeding that you cannot stop on scene. You need quick recognition at the scene, and that's going to take proper training to work out who that's going to be. Once you've recognised it, you're going to stop the compressible bleeding. You're going to give fluid volume, and that could be blood, that could be whatever you've got handy, but you need volume and it needs to go in fast. Address any obstructive shock and then get to the hospital. Be safe in the back of the ambulance, and if you need to, pull over and do things as and when they need to go. The handover is going to happen, the pre-alert from the dispatch team, not from the team who are with the patient. When you get to ED, it's a quick pit stop. Very little is going to happen in the resus room, but you brief the team to be aware. You're going to take that patient, having done whatever you need to do just to get them safely to theatre, and then you hope to have a theatre team ready to go to get in and do what the patient needs, which is to stop that bleeding. And then at the end of all that, explaining how that's all gone. Does that feel like I've pretty much got where you're at with this new kind of approach?
Yeah, in a nutshell.
Harriet, thank you so much for spending some time with us. I've actually had to drag you away from the session, so you've missed some of the talks, and I do apologise. But I think it's a really fascinating thing to think about, and focusing on what's needed for the patient, and that sometimes doing less is actually what we need to be putting at the forefront to make sure that we can get the right treatment for the right person in the right time frame.
You said it, time is the intervention. And this is that focus on time and moving the patient forward to the ultimate place of care.
Thank you so much, Harriet. It's been
Thanks.
an absolute pleasure.
It's been a pleasure to join you.